titled International Gestational Surrogacy in the United States from 2014 and 2020. This research was presented at the Pacific Coast Reproductive Society back in March of 2023. It was published in Fertility and Sterility in April of 2024, and then it was featured on the Fertility and Sterility on Air podcast. And in a small world moment, my actual future program director, Dr. Ava Feinberg, was the one who talked about my study prior to me matching there for fellowship. And so before we dive into the background, I just want to define two important terms that we'll be using throughout this study. First, a gestational carrier is or GC we labeled as, is a woman who carries a pregnancy created from gametes of the intended parents or donors. And importantly, she does not provide the egg and is therefore not genetically related to the child. And second, an intended parents or IPs is an individual or couple who seeks to achieve parenthood through using a gestational surrogate. And so to give some background information, international gestational surrogacy has increased worldwide and over the last few decades, specifically in the United States. So between 1999 and 2013, approximately 16% of intended parents using a gestational carrier were actually not from the U.S. And then there's a number of reasons for this. People travel abroad for a number of reasons, and one of it is commercial surrogacy is not legal in certain countries. There's also certain legal frameworks that are in place that some people want when they're utilizing a gestational surrogate. It also can be cost prohibitive in certain countries, specifically the U.S. And then it also depends on the political, social, and cultural context around what country you're coming from. For example, some countries may not be as friendly to single parents or same-sex couples. And so for reasons I mentioned earlier, the United States does remain a leader and a central hub for cross-border reproductive care. And it's because of the surrogacy practices that we have here, the legal protections in certain states, as well as the reproductive expertise. So for the knowledge gap for my study, there are a couple studies that tried to look at gestational surrogacy and international intended parents. And Perkins et al. In 2016 found that international gestational carrier cycles declined from 1999 to 2005, then increased from 2006 to 2013. Levine et al. Then did a study and found that international intended parents were approximately 7.8 times more likely to use a gestational carrier versus U.S. intended parents. And while both of these studies provided some information for us regarding gestational surrogacy and international intended parents, there really was no detailed analysis of cycle characteristics or obstetrical outcomes for international gestational carrier cycles. And so this leads me to my study, and our study, which was aimed to examine and compare the demographics, the temporal trends, and the obstetrical outcomes between non-U.S. intended parents and U.S. intended parents using gestational surrogacy in the United States. And so we conducted a retrospective population-based cohort study. We utilized the Society for Assisted Reproductive Technology Clinic Outcome Reporting System, or SART-CORS database. And we looked at all embryo transfer cycles to gestational carriers at U.S. fertility clinics that reported to SART between the years of 2014 and 2020. We compared non-U.S. intended parents to U.S. intended parents, and we specifically looked at demographics, cycle characteristics, use of adjunct technologies such as preimplantation genetic testing, intracytoplasmic sperm injection, and obstetrical outcomes, including clinical pregnancy, live birth rates, miscarriages, and preterm birth. And so, as you can see here, between 2014 and 2020, there were a total of 12,925 gestational carrier embryo transfer cycles involving non-U.S. intended parents, compared to 27,252 for U.S. intended parents. So the non-U.S. intended parents kind of encompassed about 32% in total over the span of 2014 to 2020. You can also see that from 2014 and 2019 in both groups, the volume of gestational carrier cycles increased, but there was a steeper increase in the non-U.S. intended parents. Specifically, you can appreciate it between 2018 and 2019. And then in 2020, as you see, both declined and there was a drastic decrease in international, and we suspect this is likely from the COVID pandemic given the travel restrictions at that time. When comparing non-U.S. intended parents to U.S. intended parents, we observe several notable differences in demographics, gestational carrier selection, and treatment characteristics. Specifically, non-U.S. intended parents were more likely to be male. They were older than 42 years of age and identified as Asian race. Non-U.S. intended parents also were more likely to choose gestational carriers that were less than 30 years of age, identify as a Hispanic race, and they also utilized additional adjunct technologies, including donor eggs, intracytoplasmic sperm injection, and pre-implantation genetic testing compared to U.S. intended parents. One thing that I have not highlighted here, but was also really striking, was the double embryo transfer. So actually in both groups, the double embryo transfer was quite high. In the non-U.S. intended parents, about 23% had a double embryo transfer, where in the U.S. intended, it was up to 27%. And so this obviously is not the standard of care, what we would recommend today. And it was back in like 2020 where my study ended, where they really came out saying that one single embryo transfer should be for gestational carriers, promoting that with ASRM and SART. So although we see this high percentage for double embryo transfers among both groups, we hope that if the study obviously was repeated, it would have gone down by now, but that's definitely something to look into in the future. We also looked at the distribution of intended parents utilizing a gestational carrier by the country of origin in the United States during this time frame, and we found that predominantly they were coming from China, 42% of them, and then the second most common were France and Spain at 9%. And a large part of that, what we suspect, is when you look at kind of the politics in those countries, the different policies, they don't allow for, during this time frame, altruistic or commercial surrogacy, and so they actually do have to go out of their country for this. It's also important to note Israel was also a close following one, and during the time frame of our study, you actually had to get approval from the government, and they only allowed it for single women or heterosexual couples, so nobody who was a single male parent or the same-sex male couples were not able to access this service in their hometown. And then a third thing that we also potentially could be playing a role is that with using a gestational carrier in the United States, you actually can get U.S. citizenship for your child. We also looked at clinic states, or the clinics of what states these international intended parents were predominantly going to, since we know that policy is very different among our states. And 75% of them were between California and Oregon, and you can appreciate the drastic difference in California even compared to Oregon, where when we're comparing it to U.S. intended parents, it actually was more evenly distributed, where we see our most populated states with California, New York, Texas. Again, a large part of this is all these states that you see here actually have a lot of good surrogacy laws that provide a lot of protection for the intended parents. Specifically, some of them are even able, before the child is born, they basically can assume the rights of the child, so that there's no issues after the child is born. And then we did look at pregnancy outcomes. And to point out, prior to us adjusting for a number of things, we saw that clinical pregnancy, live birth rates, and live birth rates were actually higher than international intended parents. And then there was lower miscarriages and preterm birth, specifically between 32 weeks and 36 weeks. However, after we did our adjustments and we adjusted for ICSI, PGT, oocyte age, use of donor oocytes, you can see the rest listed down there. There really was no significant difference after these adjustments. And so, although I commented that international intended parents were often, their cycles had more pre-implantation genetic testing and ICSI, we really have to question whether or not it's really making a difference. And in the information that I had, it can't tell you why someone had ICSI or pre-implantation genetic testing. So it really calls into question, are these technologies being utilized because they're clinically necessary, or are we just doing it just because? And so we suspect that given a lot of these, families are also, they're paying for international costs, they're paying a lot of money for the surrogacy, they're trying to optimize the odds, but truly based on our information, it really didn't change anything from a live birth standpoint. so some just take-home conclusions that I'd like to highlight is just that international gestational surrogacy was increasing up until the COVID-19 travel restrictions, and I anticipate the study will repeat it. Now that the pandemic is over, we continue to see growth. Legal and cultural barriers abroad drive cross-border reproductive care, specifically to the United States, and we have a lot of wonderful states with great laws to help protect intended parents as well as gestational surrogates. And then international intended parents are more often male, older, and used donor oocytes. And a large part of this, we suspect a lot of same-sex couples or single male parents are coming to the United States for this. And because it is so expensive, the hypothesis is that, you know, they need to be further along in their career and have the financial means to do so, which might be why they're older. And then a higher use of adjunct technologies among these cycles, but truly is absolutely necessary, given that we're not seeing much differences in the outcomes. And so because gestational surrogacy is increasingly prevalent here, you know, we have to think about the legal, the ethical, and the psychosocial complexities required for these patients and the counseling and legal protection. So there's a lot of stuff still to be done in this area, but we just have to be mindful. For sake of time, these are some limitations that are all centered around kind of the SART-CORS data base that we used for certain information I was not able to obtain. And then I just want to highlight as we end, like throughout my residency career, I've been fortunate to work with a lot of people on many different research projects, and these are just a few. These are in total everything from residency. And so I just want to say thank you to everyone and all my mentors and my collaborators, and even the medical students. They played a huge role in most of my research projects. So thank you, and also for the department for supporting all the conferences I've gone to. So just to show some pictures of us at conferences, I really appreciate it because it really has made my residency experience wonderful.
All right, we have time for a couple of questions. I'll start out with our judges.
So congratulations on your fellowship match and on your publication. It's very nice to have the finished product. But how do you, especially knowing, I didn't know at the time when I read it that you were going to go into REI, and I'm excited you are. So how do you hope, or how could these data influence sort of where things go with gestational surrogacy? Where do you hope to see it go? Where do you think it should go?
Yeah, I think that's a great question, and I think there's different, obviously, avenues with me going into REI and being like a clinician. I think I do have a responsibility to be very active in policy making. Illinois in general already has wonderful laws for infertility in general and surrogacy. So I think for myself personally, it's going to be just trying to stay an advocate and talking about being at the front of the table more from a policy standpoint in other states. I think also we have to consider, there are not only the intended parents but gestational surrogates who need to have certain protections, and really also picking a practice and promoting practices that do single embryo transfers as well, especially because we know all the comorbidities associated and morbidities for moms and babies. So that's how in the years to come I see where I can help. Obviously, I think that will grow as I get higher up in the field of REI.
And then our final question will be from Dr. Svia.
Thank you. That was a great presentation. I also, this is not a good question. I similarly applaud for looking to advocacy and how you can impact policy and impact access to care, because it is taking this broader global perspective. If you look at your data and the changes that what drives people to relocate either temporarily for medical care
No, thank you. And I appreciate that comment because I do feel like even just doing OB-GYN here in Georgia and with the laws changing, I feel like I have a different appreciation. I was raised in California, went to Florida, now Georgia, so I feel like I have very different views of how policy is very different among states, and then how you're not in your own bubble of being in one state, and you really do need to think more national, global.
Up next, we have Dr. Priyanka Mehta. She will be discussing the association between social